All right, good morning. I think we're going to get started. This is navigating normal versus abnormal with point of care ultrasound. I am Mike Hofkamp. I'm the moderator. I'm from Baylor College of Medicine in Temple, Texas, just up the road. We have Dr. Nida Cold from the University of Chicago. She's going to be speaking on pulmonary point of care ultrasound. We have Dr. Clemens Ortner, he'll be speaking on cardiac point of care ultrasound. He's from Stanford University. We have Christian Arzola, Dr. Christian Arzola. He'll be speaking on gastric point of care ultrasound. He is from Mount Sinai, University of Toronto, so he braved the borders to come over here. So thank you very much for coming to our great state of Texas. And last but not least, we have Dr. David Stahl. He'll be doing point of care ultrasound findings in the septic pregnant patient. And so our learning objectives are as follows: identify normal cardiac, pulmonary, and gastric anatomy in pregnant patients with imaging acquired through point of care ultrasound, determine when cardiac, pulmonary, and gastric anatomy in pregnant patients is abnormal with imaging acquired through point of care ultrasound, and describe the point of care ultrasound findings seen in a pregnant patient who has sepsis. All right, without further ado, we are going to have Dr. Clemens Ortner start.
Okay. Thank you very much for this kind introduction. Good morning. Thank you. It's a great honor to be here and to talk to you about cardiac point of care ultrasound in obstetric anesthesia, navigating between the normal and abnormal. Yes, very little conflicts of interest to declare. I would like to cover first, when we speak about point of care ultrasound, what actually are we doing? The definition of focused cardiac ultrasound. What is the feasibility and what are our challenging when we perform a focus in pregnant patients? Then I want actually to go, what are normal TTE values in pregnancy? I want also to spend a few words on preeclampsia and also how we differentiate in this patient population between hypovolemic and distributive shock. And we start with a case, a routine case, 40-year-old lady. She's undergoing a repeat cesarean delivery, A1 GDM, gestational hypertension, uncomplicated, more or less C-section, but they have a little bit difficulties of removing the placenta. But we go to the POCUS, everything is fine until the transfer exam where suddenly she has a big blood loss, and we rush back to the OR. And then when we do a GA, she's hypotensive, blood pressure 60/30, despite high doses of vasopressors and volume resuscitations. And these are the exact indications for doing a focused cardiac ultrasound, hemodynamic instability. And that's what we see. That's all what you can see with a focused cardiac ultrasound. She's hyperdynamic, hypovolemic. You see actually LVH and also pericardial effusion. So according to the American Society of Echocardiography, the appropriate terminology is focused cardiac ultrasound. And the defined indications are a patient that is hemodynamically unstable or a patient that is critically ill where you want to define the volume status and systolic function. And a focused cardiac ultrasound is always integrated into the clinical context. And what are the diagnostic targets that you have to be able to diagnose when performing focused cardiac ultrasound? You have to be able to diagnose systolic function of the left ventricle and right ventricle, to assess the cardiac dimensions, the volume status, to see if there's pericardial effusion, yes or no, and to identify gross signs of chronic cardiac disease and gross signs of valvular disease. And what is important in focused cardiac ultrasound is a targeted diagnostic test. So these diagnostic targets you want to be able to answer with yes or no, not more. That's a focused cardiac ultrasound. And it's also important to know what it is not. They explicitly say a focused cardiac ultrasound is not defined to diagnose aortic dissections, to diagnose hypertrophic cardiomyopathy, to also look for regional wall motion abnormalities. That's not part of a focused cardiac ultrasound, or LV aneurysm, cardiac masses, LV thrombus, or valvular vegetations. And the good thing is in pregnancy, actually, it's ideal. We have an anterior and left displacement of the heart due to the elevated diaphragm, and very often we put our patients in the left lateral decubitus. And also here, this is a group from Denmark. They have shown that novices, after 1 day of a workshop and 20 to 30 supervised scans, they were able to get more or less in 100% of patients at least one image with an image grading of 3. An image grading of 3 is image grading with a quality that is sufficient for clinical decision making. They were disagreed. They were not able to get a subcostal view. We will see that later. And what they also emphasize, if you can put your patient in left lateral decubitus. So that's for the normal pregnant patient, but how is it for C-section? So with our fellows, actually, we studied, can you do a focused cardiac ultrasound during C-section? So we had 8 fellows, and we did a focused cardiac ultrasound right after the spinal anesthesia, and then after the neonatal delivery during C-section. And we also graded these images. And in 95% of our patients, we were able to get image sufficient for clinical decision making after the spinal, and after the delivery it's a little bit more difficult, but still almost 90% of our patients we were always able to get a good image. What this graph tells you is that in particular the apical 4-chamber view, and that's not too surprising, but apical 4-chamber view, there you struggle a little bit more after the delivery, yeah? But we were still able to get very good parasternal short and long axis views right after delivery during C-section. And then if you'd say, okay, unfortunately we have no cardiac transducer, we also studied, can we actually use an obstetric transducer for focused cardiac ultrasound? So also our novices, our fellows, we randomized 70 laboring patients to perform a focused cardiac ultrasound using an obstetric versus a cardiac transducer. And in 90% of our patients, also just using the obstetric transducer, we were able to get at least 2 clinically useful images in 2 different views, okay? And also the parasternal views work great with the obstetric transducer. Apical 4-chamber views struggle a little bit more, but what I also want to draw your attention, we are still able with the cardiac transducer, but also with the obstetric transducer, also in pregnant patients to get subcostal views. Of course, there are challenges, and we know that performing a TTE can be challenging when you have small intercostal spaces in a patient with COPD, with anatomic deformities, or with obesity. But what image do you think will be more difficult to obtain? The patient with hypovolemia or this one? And I can tell you the patient with hypovolemia. So this is a frequent indication for us. When a patient is bleeding, we put the probe on. And I want to tell you one thing, don't worry. It is very difficult when they are so hypovolemic because the preload is so low that it makes the image acquisition much, much more difficult. So don't get frustrated. Once you resuscitate the patient, it's getting much easier. Yeah? And then, what is this here? So this is a breast implant. And I think in this patient population, it's also very important for us to remind us that when a presence of breast implants decrease the image acquisition feasibility to less than 50%. So don't panic. It can be super, super tough. So I want to add challenges in pregnant patients are, besides the usual parameters, also a patient that is hypovolemic can be very difficult to scan, but also a patient with breast implants. Then we also very often hear kissing papillary muscles. Kissing papillary muscles is when the papillary muscles are kissing each other in the parasternal short axis view. But it's important for us also in this patient population that distributive shock caused by sepsis, like chorioamnionitis or anaphylaxis, or also when they have an epidural catheter in place, it may present like a kissing heart with IVC collapse and normal to increased LVEF. Yeah? But the main difference is in hypovolemic shock, the left ventricular end diastolic area is very small. Compared in distributive shock, you have still a good preload, so you still have a good left ventricular end diastolic area, but the ventricle squeezes everything out. Okay, so now actually to get to the title of our talk, would you say is this normal or abnormal? I want to draw your attention to this reference here. So this is from the American Society of Echocardiography, the recommendations of chamber dimensions. In this paper, it actually tells you exactly where to do the images. If you want to take a photograph of this, because I looked you up the normal values for pregnant patients, so for female patients in a pregnancy-related age. I can also share this with you later. The same here, the normal dimensions for the aorta. And then let's get to our last case. We have a preeclamptic patient with severe features. She's on magnesium. She has an epidural in place, is in labor. And she has to undergo an emergency C-section for non-recurrent fetal heart racing. We tried to use the epidural. It's not working. We started GA. But her blood pressures are not coming up despite high doses of phenylephrine. And then we put the probe on, and we see here moderately to mildly reduced systolic function. Why is that? So here, I want to show this paper that we have recently published, where we did point-of-care ultrasounds in early and late onset disease of preeclampsia. And I want to draw your attention here that the women diagnosed with early onset disease of preeclampsia, they're at significant risk for also having systolic dysfunction. Otherwise, our preeclamptic patients, 30% have diastolic dysfunction, 20% may present with increased LVDPs, and also with positive lung ultrasound findings. But if you have a patient with early onset disease, they're at significant risk for systolic dysfunction. And here, as a last photograph, I also looked you up the normal values for diagnosing simple diastolic. I know that goes above focused cardiac ultrasound, but here these are the pregnancy-adapted values how to diagnose diastolic dysfunction in preeclamptic patients. Thank you very much. I hope I was able to give you a brief definition of focused cardiac ultrasound. Thank you.
And next up, we have Dr. Christian Arzola.
The timer. 1 second. Good morning. Gastric point-of-care ultrasound. Not working? Oh, just there. Okay, so aspiration pneumonia is there are many factors they need to coincide in order to end up in aspiration and pneumonia. And the first one is actually the one that gastric ultrasound has a role in gastric content. It's important. Still, we have closed came analysis for this situation in US. And you see 13% of cases for pregnant women had aspiration. 3 of them, they were under cesarean section, only 1 under general anesthesia, and the 4th patient had a circlage and eventually an emergency cesarean section. So you see the picture. In all of them, there was a 60% actually, it was substandard anesthetic management. With Dr. Perles, we tried to make a case for gastric ultrasound saying you can decrease the uncertainty of the gastric content and change your management, eventually change outcomes. What is the incident? This is an abstract from last year, over 1 million. I still haven't seen the article published. 1 in 100 patients, and you see the mortality. But it's important, look at that, 50% of the patients had elective surgery. If you go to obstetric, we have late 90s information, which we rely on. 1 in 700 and 1 in 900 patients, in pregnant patients, will have this complication under GA. Risk of aspiration, well, you know all of this, it's not new. Progesterone plays a major role in the sphincter, of course, under general anesthesia. And a few more risk factors that you're aware. And nature and volume of the stomach is actually we can get with gastric ultrasound. That is the issue. And gastric emptying, I'm going to talk about that. Something coming back to guidelines, which is applicable for all patients. Usually we assume fasted is empty stomach and non-fasted is full stomach. And here is where gastric ultrasound plays another dimension. It gives you more certainty of the diagnosis what you have in the stomach. We're going to use, as all point-of-care ultrasound, this frame of reference. I'm going to go one by one. Indications. It's a bedside assessment, limit examination for gastric content. It's goal director. We're going to know the assessment of the risk, and it's performed by us, clinicians, anesthesiologists. It's an acute setting when it's questionable, the MPO, unknown, any condition that can alter gastric emptying. And here is the money. Here's where we want to know this controversial thing about gastric ultrasound, gastric emptying in pregnant women. Gastric emptying, these are the latest articles that I would like to highlight. I was involved in the second one. Gastric emptying in general with scintigraphy, paracetamol, even gastric, but the second one is mainly gastric. We'll show you that. I tried to make it, we ended up in the same conclusion. So this is a summary table. It's a good one if you want to take a picture. Per trimester, definitely we have a decrease in gastric emptying. Probably progesterone goes up in very high magnitude. Second and third tend to it seems that it normalizes. Cesarean section and solid elective patients seems to be okay, non-laboring. Despite the fact that it's still some studies in 3%, you may have high risk of aspiration. We'll talk about that as well. Labor, increase by itself. Systemic opioid, increase. Epidural, we have a kind of a reversal of better gastric emptying, but still not to baseline. And of course, intrathecal plays worse than epidural opioids. Postpartum, initially you have a decrease, of course, but eventually it normalizes. So this is a nice stable summary of the two articles. So where is the indication? What happened with gastric ultrasound and gastric emptying? And here is a study, very comprehensive narrative review and recommendations. What do we do gastric ultrasound in pregnant women? This is the question. Active labor and urgent cesarean section. In those cases, we know we have a delayed gastric emptying, but we do not support in non-laboring elective C-sections because we're supposed to have normal gastric emptying. Of course, if I have a patient going for elective GA in an elective patient, I will do a gastric ultrasound to get more information. Acquisition, second point. Well, we have a position. We have the organ, fundus, body, and antrum, and it's important to understand the layers. The different layers, the most important ones are the serosa, outer layer, white, and the next one is muscularis propria, black. Those are the ones that are going to let us know where is the stomach. Acquisition. Well, 45 semi-recombinant is something we encourage to do. I will tell you why in a moment. We start supine and right lateral in the epigastric area, curvilinear probe, abdominal settings, that's it. Okay, this is the epigastric. It's a conflict with the pregnant woman, and Clemens showed us that even cardiac can be done, but it's difficult, challenging. This is pictures that we have in educational website. Nice picture. I like to use this one where the baby is actually pushing the stomach upward, so it's a difficult epigastric probe placement, steep angle. And the protocol probably is more difficult. Grab uterus is moving, it's a moving fetus. Two positions, supine and semi-recumbent. With that, we may alleviate the supine autocalval compression, but you need a slight manual displacement. There's a fast and shallow breathing of the patient. You ask the patient, try to breathe slowly, but also hold your breath in end expiration. Probably the diaphragm is a little bit higher. You can take a picture and measure. So there is a change in the protocol. Interpretation. The plane of view goes through the liver, through the antrum, which is one to pay attention. It's a surrogate what's going on in the rest of the stomach, and we're going to end up in the aorta. If you go into aorta, it means you're actually scanning the antrum, not other parts of the stomach. And this is the most important picture that I need to remember is landmarks. Landmarks, liver, like a wedge, L, aorta on top of the vertebral column. And along the free border of the liver, you're going to have the antrum with the black lining, with muscularis propria and serosa. And this is script, I always say it in workshops. Secondary landmarks, pancreas, mesenteric vessel. Do not concentrate on those. Don't pay attention. Pay attention to the primary landmarks. Let's see a few pictures. This is a picture. It's a small empty stomach, you have invaginations, and that's why you see it white. More dynamic, in which you have this a little bit of lumen with black fluid. 50% of your patients, pregnant and non-pregnant, will have some fluid in the stomach. So the concept of empty stomach is not there. 50% you have some fluid. We'll talk about that as well. When you have more fluid, you are able to see these invaginations of mucosa, and then you have more fluid. You have these white dots. Those are air bubbles. Always you have them. This is probably the body. You have a lot, but if you wait some time, these are going to dissipate. You're going to have more, wow. When you have solid, you're going to have a lot of air, and over time, the air will dissipate, and definitely you don't want to have this situation during your GA. Pattern recognition. First, it's just pattern recognition. Then you go to, every time you have clear fluid, you need to measure. What do we measure? The antrum. You can do 2 diameters, but we demonstrated that free tracing in the machine is good enough. We validated that. With the cross-sectional area, you can measure the volume with a mathematical model. We have 3 models. PERLAS, pretty good model, is the one that we use, all of us. Gastroscopy, well, it's gold standard. We did a model. It performed much worse because our gold standard was clear fluid ingestion. So there's some missing information there. The last model is good, but it tends to overestimate volume. This is my opinion. So we stayed with PERLAS. Volume. The 1.5 ml per kilo is an instrumental number. It's what you expect. Remember, I say you may have some gastric secretion. You go all the way in an empty stomach, all the way to 1.5. More of that, we may say, is some high risk. So that is the point. You can calculate, or you can use the nomogram. In pregnant patient, actually, you have the same situation, and the maximum you can tolerate is 10 centimeters square, and that corresponds the same 1.5 in volume. Last year, we validated this in a big meta-analysis. We found the same information. Maximum you tolerate is 10 centimeters square. If you have more than that, pay attention. So it's pattern recognition. We'll review that. And when you have clear fluid, you have to check that and eventually cross-sectional area. Gastric ultrasound is just diagnostic. Patient outcomes, here we're getting wrong with GLP-1. We have less, we don't have many more aspiration GLP-1, but we check gastric ultrasound is worth it, yes, because that will change your decision making. You take all your factors in consideration, you do gastric, and then you make your decision. So this is another topic, of course. Thank you.
All right. And next up, we have Dr. David Stahl. He'll be speaking about point-of-care ultrasounds in the septic pregnant patient. Oh, I'm sorry. That was out of order. Moderator Mulligan. Here we go. We have Dr. Nada Cole, and she'll be talking about pulmonary point-of-care ultrasound. And you advance the slides by just clicking.
Or not. I'll just, okay. All right. Good morning, everyone. I'm going to talk a little bit quickly because I've got a lot of slides to try to get through. So my name is Nada Cole, and I'm going to be talking about dyspnea and POCUS, making a diagnosis with lung POCUS. Just a quick show of hands. I'd like to see who uses lung ultrasound in your clinical practice right now. Okay, excellent. So not everybody raised their hand. I'm hoping that everybody will be inspired to use lung POCUS after this talk. So our framework for today is going to be the IAIM framework, and we'll first talk about indications for using lung ultrasound in patients who are pregnant with acute respiratory failure. Then we'll talk about how to actually get these images, which will be guided by the bedside lung ultrasound in emergency protocol, or the BLUE protocol. Then we'll talk about how to look at these images and distinguish what's normal versus abnormal, and finally see how we can put it all together to either narrow or actually make our diagnosis. So we'll start with a case. So in this case, our patient is less than 34 weeks. She's healthy. She feels well. She does have early onset preeclampsia with severe features. She presents with a category 3 fetal heart tracing and requires an emergency C-section under general anesthesia. Shortly after delivery, she develops a brisk postpartum hemorrhage requiring 2 units of transfusion, and then she stabilizes until her oxygen saturation drops to the low 80s. You switch to manual ventilation, you give her 100% oxygen delivery, but it doesn't really help too much, and you can't figure out what's going on. So what do you do? That's where POCUS comes to the rescue. You can tell I like rhymes. Okay, so what are the indications for using lung POCUS in this patient population? So we know from non-pregnant individuals that lung ultrasound has excellent specificity and sensitivity for making a diagnosis of pulmonary edema, pleural effusion, decompensated heart failure, or pneumothorax. And this is comparable to CT scanning and actually better than chest X-ray. In addition, we know that unlike chest X-ray, lung POCUS can differentiate acute lung injury from pulmonary edema. It detects interstitial syndrome, which is just a blanket term for any infiltrates in the lung alveoli or interstitium. So it'll detect that before chest X-ray and before clinical symptoms develop. And lastly, it will reflect dynamic changes that are going on in a patient over time. Okay. So now we know that lung ultrasound is great for those few diagnoses that I mentioned on the last page. Can we actually go further into a differential and see how it can help us? So I've grouped our differential for a patient like ours into 3 buckets here. Those buckets are categorized by common sort of presentations, I guess you could say: interstitial syndrome, no pleural movement, and pleural effusion, and also by what's considered to be an ideal location for scanning for each of those buckets. We're not really going to talk about pneumothorax because clearly we don't have a lot of time. Okay, so here's the Blue protocol, the scanning that's recommended. This was first published by Dr. Lichtenstein, Daniel Lichtenstein, in 2008. And it combines what I like about the Blue protocol is you only need to scan 3 locations per side to get a highly sensitive and specific, potentially, diagnosis. There are 2 anterior locations, the upper and the lower blue points. For the upper blue point, you're going to look with, he recommends a microconvex probe. I just use an abdominal probe, curvilinear probe with abdominal settings. Always put your probe in the longitudinal axis with the orientation marker pointing to the head. That'll give you an image on the screen with the head on the left side and the feet on the right side of your screen. So the upper blue point, first of those 2 anterior locations, second to third intercostal space, mid-clavicular line, that is the best place to look for interstitial syndrome. However, you can't make a diagnosis of interstitial syndrome from one location alone. So you're going to look at the lower blue point. You want to look for interstitial syndrome primarily in the anterior locations. At this lower blue point, you're also going to be able to see no pleural movement really well. So that's going to be cases where you have a pneumothorax primarily because air will rise at the most superior location. So that is where it is when the patient is supine. And also, again, the interstitial syndrome right there. If you go directly posterior from that lower blue point, you'll get to the posterior lateral alveolar pleural syndrome point, PLAPS point. You'll see that I put a little squiggly because this is not exactly the PLAPS point. Where I like to go is a little bit caudad to that so I can see the liver in my view as well. And that's where you'll look for pleural effusion. So here's an example of a normal POCUS image that's from an anterior scanning location. At the top, you can see the pleura. It's going to have what we call sliding, or you can see that sort of glistening movement or ants on a log. Below that, these sort of less hyperechoic reflections. They're just artifacts from the pleura, and they're at equidistance from the probe to that first pleural line. So you can kind of see that second day line coming into view. So that's all normal. Here, same locations anteriorly, you're going to be able to see interstitial syndrome, which is diagnosed, think of 2s here. So you're going to see greater than 2 B lines between 2 ribs at more than 2 locations, or at least 2 locations on both sides. And these B lines are going to look like these lung rockets coming down from the pleura all the way to the bottom of your screen, approximately 17 centimeters deep. And they move with respiration. They often obliterate A lines. Here's another example of interstitial syndrome. Here you'll see that the pleura is more coarse and jagged. That is common in infectious or inflammatory pathologies. And then just to be complete, pneumothorax, like I said, the most superior point on the anterior chest, you're going to see a lack of lung sliding because the air is there and the pleura is just not moving. What you want to do to actually be able to diagnose it is scan posteriorly until you get to what's called a lung point, which is the intersection between normal lung and that sliding. Normal lung with the sliding and the absence of sliding. Okay, moving on to the PLAPS point. Here you are looking at the liver, the caudate section on the right, and the morcephalate on the left. When you have lung inspiration, it's going to expand. You're going to see it coming over the liver like a curtain, hence the name curtain sign. Spine will not extend above the diaphragm in your view because air will not allow the echoes to pass through it. Contrasting that, you have pleural effusion where you will see what's called a spine sign because the echoes will pass through fluid, and that is an example of a pleural effusion, that fluid. And you will not see much of a curtain sign here because you've got fluid that's obscuring, preventing the lung from descending all the way. Okay, so if we go back to our patient, let's say, for example, that we scan her anteriorly. We can see B-lines everywhere, nice lung sliding everywhere, and crisp pleura. Then we go to the PLAPS point, and we do see a curtain sign. We see no spine sign, no pleural effusion. So what do we have? Well, we saw the B-lines. We've got an interstitial syndrome. We saw lung sliding, so no pneumothorax, no apnea, and we did not see a pleural effusion. So we've got a diagnosis of interstitial syndrome. Can we narrow this down even further? In fact, we can categorize sort of interstitial syndrome into two types. This is taken from a table from a website that listed at the bottom that I really like. And so you can see on the left, cardiogenic pulmonary edema, and on the right, infectious or inflammatory infiltrates. So these are some of the characteristics that will differ. So the pleura in your pulmonary edema is going to be pretty crisp, and you will see sliding throughout. Unlike on the right, you'll see maybe some lack of lung sliding in some places, and as we saw in that earlier clip, a coarse and jagged pleural line. B lines will be symmetric, and they will actually increase because it's fluid with gravity, whereas on the infectious side, you'll have asymmetric B lines that are not gravity dependent. You'll see clearly with cardiogenic causes, you're going to see heart failure, volume overload, whereas assuming that there's no ongoing cardiac failure as well, with infectious inflammatory conditions, you'll see consolidations potentially and air bronchograms in those. So common diagnoses with the pulmonary edema, certainly cardiomyopathy. If they've had a transfusion, you could diagnose TACO. And with a pin in it, I'll say preeclampsia as well. Infectious or inflammatory conditions, if that's a diffuse situation, you're going to see acute lung injury potentially, or ARDS, trolley, fibrosis, and so on. But if it's focal, think of pneumonia, atelectasis, tumor, and so on. The pin in the preeclampsia was just that while this is going to fall into that cardiogenic pulmonary edema category in terms of your imaging, it's not always caused by cardiac dysfunction, right? We know that pulmonary edema and preeclampsia is going to have a number of different reasons to be there. So it could be cardiac dysfunction. This could be due to increased vascular permeability because of endothelial dysfunction, certainly decreased oncotic pressure, and then the things that we do to them, like giving them tocolytics and too much fluid. So just quickly before I finish, I did want to highlight the same paper that Dr. Ortner talked about. And what I've circled instead of the diastolic dysfunction here is the prevalence of pulmonary interstitial syndrome in both early onset preeclampsia with severe features, as was studied in this paper, and the late onset preeclampsia, as was in Dr. Ortner's earlier paper from 2019. You can see that it's quite similar. About a quarter of these patients had pulmonary interstitial syndrome. And the other table that I want you to see here, because this kind of brings it home, is that you'll see, contrary to their hypothesis, there was actually not any association with early onset preeclampsia with severe features, the cardiac dysfunction. There was no association between that and pulmonary interstitial syndrome, which was not the case in several other studies looking at preeclampsia that were all comers, like late onset in Dr. Ortner's case, and just all comers. So that's an important thing to remember, because as Dr. Fenton pointed out in her discussion of this paper, it means that there may be other mechanistic pathways that are going on to create this pulmonary edema in early onset preeclampsia. So back to our patient, could her pulmonary edema be just the result of her preeclampsia, even though she may not have had cardiac dysfunction? Yes, absolutely. Okay, key takeaways. I want you to remember that lung POCUS is fantastic. It's comparable in sensitivity and specificity to CT for making a diagnosis, better than chest x-ray. It can also do more than chest x-ray. You can trend it over time very easily, and it'll differentiate between lung injury and pulmonary edema. We'll distinguish, as I said, changing features over time, and you must corroborate this with your clinical context and with cardiac POCUS to make your diagnosis. And so I'll leave you with that and say practice anywhere, anytime, and thank you.
All right, and last but certainly not least, we have Dr. David Stahl, and he will be speaking of point-of-care ultrasound in the septic pregnant patient.
All right, so now we're going to try to put this all together following the last case, this preeclamptic patient who went for a cesarean delivery, who now we find winds up in the ICU. And what I want to talk about here is how to integrate these different modalities of ultrasound in the management of more complex patients. And so we see often that our preeclamptic patients recover from a cesarean delivery and are hypoxic. We often see that they recover from cesarean delivery and have a hemorrhage. In this case, the patient is in the PACU, now hypoxic and now bleeding, and you're wondering, what could it be? Could there be a unifying diagnosis here? Are these just two related problems? Because she is preeclamptic, she got pulmonary interstitial syndrome, she had preeclampsia and a complicated cesarean delivery, and she has bled. And here, the differential diagnosis for hypoxia and hemorrhage are both broad. The hypoxia differential includes airspace disease, includes airway problems, includes systemic syndromes like sepsis. Hemorrhage is definitely atony until proven otherwise in the postpartum setting, but it could be retained products of conception, could be other problems as well. And when we think about maternal hypoxia here, there are things that kind of go into the lung, the systemic symptoms like sepsis, a pulmonary embolism, or medications. There are the things that back up into the lungs, like heart failure and preeclampsia, as we just discussed. There are also all of the interstitial problems like aspiration, as was mentioned, infection, and edema. And so when I think about the management of these complicated patients, it really isn't just reaching for the ultrasound. It's talking to the obstetric team and saying, hey, what do you think's going on? It's figuring out early, is this patient sick or not sick? It's using true physical exam, actually listening to the patient's heart and lungs. And then it's getting laboratory values and adding that into your management of the ultrasound. And so, as Dr. Cole mentioned, I often find that that lung ultrasound for the management of hypoxia in pregnancy is most easily accomplished from that upper blue point. You can see on the anatomy here, or kind of turned laterally here. And this is actually an image taken with a phased array probe. So you can use the cardiac probe, you can use the curvilinear probe. You'll get a narrower field of view with the phased array probe. But you can see on this image the nice pleural sliding at the top. Here, you can see the echoing A lines going down here. And this looks like a pretty normal image. Contrast that with the image that we see here, where you've got great pleural sliding, but you have the speckly B lines echoing all the way down the image. And so in thinking about this patient who is hypoxic and bleeding, called the OB team and they're worried. We don't know what's going on, but this looks bad. We go to the patient's bedside, she's sick. Listen to her heart, it sounds normal. Listen to her lungs, she's got diffuse crackles, and we get a blood gas, and it looks like she's got a metabolic acidosis as well as being hypoxic. And then, of course, the point-of-care ultrasound showing us these B lines. And so going back to our diagnosis, because I think whenever we use point-of-care ultrasound, we want to think, like, what do we think this might be? And then test our hypothesis with the ultrasound. this is probably not just her preeclampsia acting up. It doesn't explain all of these findings. It's probably not medications. We worry about something going on in the lung because we saw these B lines echoing down, and we actually saw them all over the place. And then I think this is an opportunity to think about not using lung ultrasound in isolation, but combining it with cardiac ultrasound to interrogate the heart as a potential problem here as well. And for my cardiac anesthesiologist in the room, I know how you like to enter. But in this case, we had two questions, right? We have this hypoxia and this pulmonary interstitial syndrome, and we wonder, like, hey, is this pericardium cardiomyopathy or left ventricular failure backing up into the lung? Is this right ventricular failure and amniotic fluid embolism leading to coagulopathy and bleeding and blood not getting into the lung and being hypoxic? And I think this is the perfect case where you've got this rapidly decompensating patient and you have a really broad differential that have very different treatment pathways. And so when we looked at this patient, this is the parasternal long axis view. So you can see in the upper right, this is second or third intercostal space, probe marker pointed to the right shoulder. This is, I find, to be the easiest view to get in the pregnant patient, and that agrees with Dr. Ortner's study. But you can see that this is the right ventricle here. This is the left ventricle and long axis. Here's the mitral valve. Here's the aortic valve. And the heart looks like it's squeezing well, and it doesn't look like it's particularly volume overloaded. It looks like, if anything, it is underfilled. When we rotate the probe marker 90 degrees so that now the probe marker is facing the left shoulder, you can see a short axis view. And this is the left ventricle here in cross section. And again, looks relatively hyperdynamic and underfilled. So this helps us substantially in the management of this patient, because now we think this is not likely to be an amniotic fluid embolism. The right ventricle looked okay. The patient looks underfilled, so this could be bleeding. And this is a patient who had worsening hypotension, got started on a norepinephrine infusion, gets moved to the intensive care unit. Hypoxia gets progressive because we're giving more volume and requires intubation. And then we get some more labs back, and the lactate's 8.3. And so this is where kind of putting the whole picture together can be helpful, because this is what sepsis looks like in pregnancy. And I think it is challenging to diagnose sepsis, because for most of us, when we think about sepsis, we think of grandma in the ICU who has pneumonia. Grandma, is an older age person. She presents with complex medical problems. She generally presents with hypotension as her symptom of sepsis. And what's interesting about the septic patient in pregnancy is that of the septic patient not in pregnancy is that most of them, even if they're very sick, will live more than 72 hours. And most of the time we're treating MRSA and gram-negative rods. In maternal sepsis, these patients present primarily with respiratory symptoms and bleeding. Two things that we don't think of in the general milieu of sepsis. And of the patients who decompensate, they decompensate rapidly. These are some of the scariest patients to take care of in the ICU. And when you meet them on the labor floor, identifying them early can really change the course of their treatment. And so I just want to make the plug here that anytime you have a bleeding patient that doesn't seem like it's just simply bleeding, sepsis needs to be on your differential diagnosis. Just to go a little bit off topic here, but 20% of maternal mortality in the US is sepsis. This is the highest category of preventable maternal mortality in the US. And when we think about the management, this is getting blood cultures and starting antibiotics, and then getting source control, which usually means evacuating the uterus. And then, of course, fluids and vasopressors. So this patient actually goes back to the operating room, gets the uterus evacuated. To get source control, we get blood cultures, we start broad spectrum antibiotics. Patient gets started on fluids, gets serial blood gases and vasopressors. And now I want to dip into another part of ultrasound that is kind of an emerging area, which is 2 days later, this patient is progressively hypoxic. Now they have actually worsening acute kidney injury. Despite you feel like you've done everything right to fix their sepsis. And this is where we start to think about de-resuscitation in the ICU. And I recognize that most anesthesiologists don't get to this stage if you're not in the ICU, but occasionally we take these patients to the OR for other reasons. And so I think knowing kind of about this in theory is helpful. And this is where the VEXUS score comes into play. And this is a relatively novel area of point-of-care ultrasound that we're starting to see in critical care. The first descriptions were about 5 years ago. It was validated primarily in cardiac surgical patients. The idea that you could look at venous congestion as a predictor of organ dysfunction. So in this case, this score predicted acute kidney injury better than many other aspects of our care. And I'm not going to teach you how to do the VEXUS score. I will say in general, it is a challenging kind of third level ultrasound skill. But just to give you an overview, the way VEXUS works is starting with an IVC diameter, then looking at hepatic vein Doppler and seeing this reversal of flow, then moving on to portal vein Doppler, and then finally renal vein Doppler. And if you score this up to a grade 3, that's the patients who have venous congestion. Again, this is just something to like park in the back of your mind because I think we're going to see it coming down the park in the future. And I think when we take patients to the OR who are in this stage of their care, thinking about how we can contribute to limiting fluids and kind of decongesting them will improve their outcomes longer term. So in this case, the patient got decreased IV fluids, started on diuretics, and made a complete recovery home. So my biggest take-home message for you today is if you have a patient who's hypoxic and bleeding on the labor floor, you have to think about sepsis and that you can use point-of-care ultrasound, including lung and cardiac, to help you tease out that diagnosis in this very complex picture. Thank you very much.
All right, at this point, I'm going to have the panelists come and take the table and the microphones. We're going to entertain questions. I'm going to be picky and ask you to address it at the microphone so we can have it in the recording. Please tell me your name and where you're from.
Sure. Hi, I'm Beck Marakimov. I'm a cardiac anesthesiologist and the POCUS director from University of Kentucky. Thank you for this panel. Great talk. Just wanted to make a couple of comments and see whether you agree or not. The first topic on the cardiac focus exam, in terms of the diastology, based on the echo guidelines, they actually recommend against doing that in a patient who is anesthetized under general anesthesia because it drastically changed the loading condition. And I would also argue this is probably not to be done in a patient who is actually actively receiving neuraxial anesthesia for the same reason. So I think if you want to study that in a particular patient, you should do it before you anesthetize them for any reason. Second comment I want to make is about the gastric point of care ultrasound and its potential limitation in the patient who had a gastric surgery in the past. I think it's not necessarily validated well for this population. And the last comment I want to make about this last case in a septic patient, I would actually disagree that the point of care ultrasound which you showed, I would disagree that this patient has normal RV because RV was quite dilated and quite concerning. I was not sure what was the cause of it. Was it hypoxia causing RV dysfunction? But I would disagree that the RV was normal. Thank you.
All right, Dr. Stahl, would you like to respond?
Yeah, so it is, you're right that the RV in that case is not totally normal. I would argue that I guess my point in the imaging is that in the case of an acute AFE or another acute RV event, the appearance of the RV is going to be quite a lot more dramatic than we saw in this case. And so while we see septic cardiomyopathy, while her hypoxia plays a role in her RV function, that was not the primary cause of her dysfunction. But good pickup. Do you want to talk about the diastology?
Yes, thank you for your comment. I agree, of course, the diastology is nothing to diagnose for a patient during the general anesthesia. And I also want to, again, to emphasize that, of course, diastology is not part really of performing a focused cardiac ultrasound. What I still wanted to share this slide because there were new recommendations on diastology just coming out in July. And I had to really dig deep in order to find actually the normal and reference values that apply to female women at the age of a childbearing age. And that's what I wanted to share on this slide. And also, it's a little bit a simplified approach how you can still do diastology if you're able to use some pulsed wave Doppler and some tissue Doppler. But I agree, diastology is not to be done during the general anesthesia.
Thank you for bringing up that issue. In a short presentation, there are much more information about gastric ultrasound to make a more comprehensive lecture about it. But definitely, there are limitations in point-of-care ultrasound gastric. Any gastric surgery before the ultrasound, of course, is going to be altered. You cannot make the models, and images are going to be different. One. Second, patients with hiatus hernia also, you will not have cannot use the same parameters in terms of volume, all of that. So yes, there are limitations. And as I mentioned, the protocol might be more difficult, is what you have to say from the beginning. But trust me, if you start doing it regularly, then you can master the technique as you do it in a regular non-pregnant patient.
I really have no questions. I just want to say thank you very much. This is the best panel I have listened to for a long time. And you all guys did an awesome job, especially when you were talking about gastric ultrasound and you just put it into clinical context. You know, ultrasound finding is not the most important. You're a physician, make a good decision. And that's what we need to do. And I really appreciate you all. Thank you very much. Keep doing good work. I'm surprised this room is not full. But thank you.
A comment?
Sure.
Yeah, thank you for your words. I want to emphasize something already mentioned, but it went very quickly. In evidence-based medicine, you have diagnostic accuracy, decision-making, and outcome. Everyone is looking at outcome. For years, residents would ask me, Christian, pregnant patient, it's not going to change my outcome. You're still going to put the patient to sleep, rapid squeeze induction, blah, blah, blah. And then I was silent, until I figured out, because I should know this thing, yes, diagnostic ultrasound is diagnostic. The final outcome will not happen, most likely, if you do a good decision, make it in the center. So there is the money, is what you do. The same thing, sorry to repeat it, GLP-1, people say, oh, big database, 1 million, you don't have more pulmonary respiration, great, wait, it's not a problem. No. We know from studies, even in JAMA, in big journals, we have more gastric content with GLP-1. But then what it's going to do is what we do. So if we have more information, you can change your management. Thank you.
I would like just to add one more thing. This is first time I've listened about point-of-care ultrasound and OB, because I really haven't been doing it very much, but I work in a small hospital that has a residency program, and I'll just bring this directly into my residency program. Thank you very much.
Sorry. Hey, good morning. Great talk, excellent panel. Highly agree with that comment earlier. My name is Ian Molyneux. I am Assistant Dean of Student Affairs at University of Tennessee Health Science Center and critical care anesthesiologist. I do a fair amount of OB as well. One of the comments or issues that we have is that sometimes when you have fellows and they start talking about IVC ultrasound in pregnant patients, you have to be like, well, was she flat on her back, etc. Like, and how is it that now we are trying to mitigate this issue of the IVC compression with looking at fluid status using point-of-care ultrasound in fairly gravid patients in particular?
Well, I have to be honest, I think in the population, the image acquisition of the IVC is to me a little overweighted. On one hand, what we've been able to show is that actually you have still a decent feasibility of doing the image acquisition of the IVC in this patient population, but you have to sit them up. On the other, we should not forget it's a marker of right atrial pressure. It's not, especially in spontaneously breathing patient, the predictive value to predict fluid responsiveness, and that's what very often it is used for, is actually very, very low. So I'm not using it for that. I think it's still the most useful for this focus cardiac ultrasound if you do your parasternal windows. And you can also do this with your obstetric probe. That's what we've shown. And this helps you so much to differentiate what's going on with this patient. Are they hypovolemic? Are they decreased systolic function? Or is there anything else going on? Yes, so you can do the IVC, but don't focus too much on it. That's my take home.
I have a comment about that. There's a very nice study done a few years, it was presented in SOAP. Autocaval compression definitely happens when you have a patient supine position, but sometimes you may not have hemodynamic consequences from that. And that was confirmed with that MRI study. So something happened when they're compressed partially, and other systems try to compensate that. But as soon as you put a spinal and epidural, there is when most of these cases that probably didn't have a hemodynamic consequence are going to be evident, and the patient will have a problem. So as soon as you put your epidural, your spinal, C-section, the lateral, the wedge on the hip, under a hip can help. And we know there's controversy how much you need to put it in order to have a difference. But that's important to mention.
All right, with no further questions, we'll end 5 minutes early. Thank you so much for attending the talk.